Altered Physiology, Mechanisms of Disease 2, a continuation of our lectures on the cardiovascular system. Here in episode 5, we will focus specifically on congenital heart disease. In the preceding lecture episode, we talked about the prevalence of congenital heart disease, as well as some of the trends, and we introduced the concept of obstructive defects. In this particular episode, we will talk about defects which affect pulmonary blood flow. And so we'll start here by looking at defects with increased pulmonary blood flow, and that is the atrial septal defect. In the case of the atrial septal defect, or ASD, it is an abnormal opening in the wall between the atria, so between the left and the right atria. This will allow blood to flow between these two chambers. Now, there are a few different types, but that is just more for your interest. And more importantly, it is important to realize that there is a wide continuum of disease in individuals with ASD, but typically individuals can actually be asymptomatic at an early age. And so symptoms may only present at a later age during bouts of physical exertion or exercise. This is in contrast to a ventricular septal defect, also known as a VSD, in which case the ventricular septal wall has not formed properly. There is abnormal communication between the ventricles, and this tends to be the most common type of congenital heart lesion. Notably, this can be asymptomatic, but in more severe cases, you have increased pulmonary blood flow from left to right shunting, and it can evolve and lead to pulmonary hypertension. Now, let's take a look specifically at tetralogy of Fallot. This syndrome is represented by 4 defects. Not only do you have a ventricular septal defect, but you have an overriding aorta, you have a pulmonary valve narrowing, or also known as stenosis, and as a compensatory mechanism to try to overcome the increased workload, you have right ventricular hypertrophy. So the right ventricle muscle actually increases in terms of size. Now, in this particular case, there are a number of clinical manifestations, including acute cyanosis at birth or gradual cyanosis, gradual clubbing or pore growth, hypercyanotic spells, and if untreated, it can lead to emboli, stroke, brain abscess, and seizures. Now, let's take a moment to look at the hypercyanotic spells. These spells represent sudden attacks of severe cyanosis that develop with time as the right ventricle increases in size. They are typically prompted by things such as feeding or dehydration, and these spells are a warning sign that surgical intervention is needed. Children will develop ways of averting spells, typically by squatting or drawing the legs up, as shown in the diagram on the bottom right. While it's not exactly known, this mechanism may be useful. The drawing in of the legs will increase venous return, or the amount of blood that's returning to the heart. Cardiac output will therefore increase, and increased pulmonary artery flow helps to bring up and improve the oxygen saturation to counteract the episodes of severe cyanosis. Now you may be wondering how this occurs. The drawing in of the legs flexes the hip and actually leads to a distortion and occlusion of the femoral artery. This will lead to a sudden increase in the systemic vascular resistance. The next slide highlights the issues surrounding tetralogy of flow. So the main problem is that you have an anterior deviation of the outlet septum. The deviation of the septum will also compromise the right ventricular outflow tract, and therefore the pulmonary vessels are small, narrow, and obstructed. Hence, you have pulmonary stenosis. This is shown in the diagram on the screen. Next, because the outlet septum is deviated, there is a ventricular septal defect. And finally, the right ventricle has to work really hard. And so it has two options. It either pumps blood through a narrow, obstructed pulmonary artery, or it pumps blood against a very high pressure. And therefore, we consider the right ventricle to be pressure loaded, and as a compensatory mechanism, right ventricular hypertrophy will occur. This diagram just represents the pumping of blood between the right and left chambers against the high left ventricular pressure that leads to a pressure-loaded right ventricle becoming hypertrophied. Now, because of the pulmonary artery stenosis and the right ventricular hypertrophy, eventually with time, if not immediately, the shunt that is shown on the screen here between the right and the left chambers will occur, and the baby will become cyanotic. Now let's take a look at the surgical repair of tetralogy of flow. So essentially, it involves the patching to close up the ventricular septal defect and patching the pulmonary artery to make it wider and relieve the stenosis. Individuals can have a stent implanted to alleviate the stenosis in the pulmonary artery. The repair is typically done during the first year of life. It can be done even as a neonate if severely cyanotic. And finally, here is a diagram showing you the patching and surgical repairs that can be done, once again, to the ventricular septal defect and to the pulmonary artery, respectively. Now, late outcomes in tetralogy of flow are as follows. So the majority of babies born with congenital heart disease that have tetralogy of flow actually survive into middle age and perhaps beyond. The functional health status, physical activity, and comorbidities may change across the lifespan. The late outcomes, though, may include right ventricular overload, which leads to a dilatation, right ventricular dysfunction, regurgitation of the tricuspid valve, which separates the right atria from the right ventricle, and the presence of arrhythmias. In patients with tetralogy of Fallot, pulmonary valve replacement may be required later in life. And so this brings us to a sample checkpoint question about a pediatric patient who is diagnosed with a cyanotic heart defect. And the answer is A, tetralogy of Fallot.